So here we've got some ECG readings. The one up here at the top, it says sinus rhythm. So what does that mean? Normal. And if you go through and look, each spike is a QRS complex. And you see on either side of each one a P wave and a T wave. So for every contraction P, QRS complex T. P, QRS T. And it repeats like that at steady, predictable intervals. And that looks good. The next one down here on the bottom says junctional rhythm. We used that term a second ago. Junctional rhythm is what you call it when what is happening. Right. So we have a non-functional SA node. The AV node has got to take over the work. And that's what's happening. Now, we already said we knew one thing would happen from the AV node having to take over. That's what? Slower heart rate. So remember, this is happening over the course of time. So notice how these are more spread out than these. That indicates that it's happening more slowly, as we would expect. But now that we know a little bit about the electrical activity on the ECG, what else should we notice with no SA node activity? There's no P wave, right? Remember, the P wave started when the SA node generated the signal and then it traveled through the atria. Well, if the SA node's not working, we wouldn't see that. So let's look at each heartbeat. There's a QRS complex. Okay, I see a T wave over on this side, but to the left of it, nothing. And that is what you would expect with junctional rhythm. Then down here we have a second-degree heart block, which is what we would call in here a partial heart block. What is a heart block? Close. But the problem here is not the SA node, it's the AV node. What is the AV node supposed to do? Delay the signals. A heart block is when the AV node, rather than delaying the signals, stops them. Now I called this a partial heart block because if you'll notice, sometimes we've got P wave, QRS complex, T wave. That's fine. And it starts over in P wave and then nothing, right? And the heart tries again. P wave, QRS complex, T wave. Again, a normal one, and then a failed one. Okay? So what we're seeing here is approximately 50% of the SA node signals are not making it through. That would be a partial heart block. And then down there at the bottom is ventricular fibrillation. No discernible anythings. It's just going nuts. Okay? The electrical activity is unpredictable and incoherent, and you therefore have no contraction of the ventricular walls. So, if you'll notice, and by the way, taking my class, you now have to be annoyed by the same things that I am in TV, okay? So when you watch TV, like a medical show, right, they'll be looking at the heart monitor, and then what happens? All of a sudden, flatline, right? And then it's time to shock them, right? No. If they're flatline, no. This is what it looks like when they need a shock, okay? This is what they should have on the heart monitor, going all nuts. If it's flatline, they're probably already dead. We can take certain measurements on an ECG reading and interpret what that means based on what we see. So the first one up there is the PR interval. The PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. So if I pull up our ECG reading again, I think it was actually marked on there. Here's our PR interval. Beginning of the P wave to the beginning of the QRS complex. And what that's telling us is the amount of time between when the atria begin to contract and when the ventricles begin to contract. Okay? We can also take a look at the ST segment from the end of the QRS complex to the beginning of the T wave. So from here to here. This is ventricular depolarization. This is ventricular repolarization. So this is what causes it to contract, and this is when it begins relaxing. So the ST segment is the amount of time when the entire heart is contracted before it begins to relax. And that can be significant too. I think I said earlier, one of the things you can look at to check to see if a person has had a heart attack is an elevated ST segment, meaning this will be longer than normal. It will take a greater amount of time for repolarization to occur. You might also see an inverted T wave, which means that rather than going up, it goes down. This will also be in the same lab, heart sounds. Okay? So if you guys are aware, when you hear a person's heartbeat, you don't hear one sound, right? What do you hear? Two. You know, if you feel your pulse or something, every heartbeat comes with one impulse. But when it comes to heart sounds, every heartbeat comes with two sounds. They describe them as lub-dub, or lub-dub. Just sort of supposed to be what it sounds like, okay? But that is not what they are called. I'm sick of this showing up on tests, people's answers. They are called S1 and S2. Which just means sound 1 and sound 2. But, you know, if I put on a test, when these valves close, it will create what heart sound, you write lub, you're going to get that wrong, okay? So, what is creating those sounds that you hear when you listen to a person's heart?
The valves closing.
The closure of the valves. So when something causes a set of valves to close, they slap together and make a sound that can be heard through the person's chest wall. Now, of course, we normally listen with a stethoscope, but you can hear all this simply by just laying your head on a person's chest, which incidentally is the way that they used to do that. They were listening to people's hearts before they had stethoscopes, and the stethoscope was invented to put a little distance between doctor and patient, as female patients became uncomfortable with their male doctor's head on their chest. The S1, or the first heart sound, is caused by the closing of the AV valves. The second heart sound, S2, is caused by the closing of the semilunar valves. So what causes the AV valves to close?
Pressure?
Yeah, so remember, valves close because of well, they open or close because of changes in pressure. So the AV valves close when the pressure builds in the ventricle. When the ventricle begins to contract, it generates pressure that closes the AV valves. What causes the semilunar valves to close? The end of contraction, because now the ventricle is not contracting as hard anymore. It's beginning to relax, and the pressure in the arteries forces the semilunar valves closed. So when you're listening to a person's heart sound, and you hear boom, 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 the amount of time between those two sounds is it's basically bookending the beginning and end of ventricular contraction. Again, we have a term here representing abnormal. Heart murmur means there's some kind of abnormality in the way that you hear the heart. And this generally represents a problem with the valves. So we talked about stenotic and incompetent valves earlier. That will sometimes result in abnormal sounds because you don't have necessarily a nice clean opening and closing of valves. There's leaking at some point. If it's incompetent, or a difference in the sound between them if it's stenotic, as the valve is not opening all the way. So if you want to try and, like if say you're listening to a person's heart and you hear a murmur, you hear an abnormal sound, you may want to try and figure out which valve is affected, right? So there are actually different points on the person's chest where you can place a stethoscope, or your ear if you're old school, to hear different valves more clearly, okay? So you see over here, aortic valve, there's the auscultation point for the aortic valve, for the pulmonary valve, for the tricuspid valve, and for the mitral valve. And using that, you can hear each of the valves more accurately. I do like to make, this is a good picture, which is why I keep it, but I do like to make a small change to this, okay? So the aortic valve is best heard in the